high-risk patient is a patient who has either individual high-risk features or a combination of these features, and high-risk features include older age, diabetes, chronic renal disease, peripheral artery disease, and high cholesterol levels, high blood pressure, uncontrolled high blood pressure. This is very difficult because even in one region or in one continent, the patient journey can be very different, and this patient journey depends on the healthcare structure, the budgets of the country. So it may be very much different in India than in Germany, and in France it can be different than in Italy. But I'm sure that there is no perfect system where a patient enters a route where he will have the best treatment. There are too many interfering physicians, too many steps between the professionals. Most countries stick either to the North American guidelines or to the European guidelines regarding cardiovascular disease or coronary artery disease and most other guidelines. And although there are small differences between these major guidelines, in principle they are very similar. I think that countries that adhere more to guidelines, they have systems that reward or punish the non-adherence to guidelines. That should be the driver for guideline adherence in most instances, but not always. Non-cardiology specialists play a huge role in the patient following an infarct, because this patient usually after a few weeks or months after his index event will seek medical attendance for any other disease, including his dentist, a gastroenterologist, and or orthopedist. So all these disciplines should have insights into the pathology of the patient's disease, on his treatment, on recommendations on interruption of therapy, discontinuation, dosage, duration of a pause, and so forth. They should have a very close interaction with the treating cardiologist or the specialist who, for example, did the coronary intervention during the index event. To bring all disciplines together is a very difficult challenge. So that makes the high-risk patient is that he does not only have a coronary artery disease, but he also has peripheral artery disease, he has diabetes, he has renal failure, and he will not only seek attendance by the cardiologist. So every of these physicians should have broader insights into the major disease of the patient. So a cardiologist should know about diabetology, he should know the principles of treatment, and on the other hand, the diabetologist, the diabetes specialist should have the more comprehensive look on the risk of the patient, not only the therapy of blood sugar control. Now, as we have more insights into pathophysiology and how risk factors are linked together, for example, diabetes and heart failure due to coronary artery disease, we start to implement findings from diabetes studies into heart failure practice or treatment of coronary artery disease. There are drugs, diabetic drugs, that help to reduce hospital readmissions, improve mortality, and are able to act as diuretics, particularly in patients who have heart failure as a comorbidity. We have a lot of tools in secondary prevention, and still there is an event rate that is unacceptably high. Although we reduced recurrent events a lot during the past years, we still have an unmet need to refine our efforts to reduce further. And that is either by means of pharmacological drugs or by lifestyle interventions or by novel technologies like assist devices for heart failure to prevent rehospitalization for heart failure, or bridging to destiny for patients who could be heart transplant candidates. So there are a lot of novel technologies and drugs that might help to further reduce recurrent events. So I think there are some areas where there's a lot more space for improvement. For example, we still can improve LDL cholesterol lowering. We still can reduce recurrent infarcts by promoting dual antiplatelet therapy. I think blood pressure control is still imperfect and can be improved by drugs that are effective and have few side effects.